Welcome to the Senior Moment. This is Connie Clark with Home Helpers, and this afternoon in the studio with me, I have Dr. Justin Rader, and he is with a couple different dental practices here, but most notably with Durney. You are the
Dental director at Durney.
of Durney, and the reason I've got him in here today is a few months ago at Panhandle Health District. They had a diabetes day there where they had all kinds of information tables on diabetes testing and that sort of thing. And Dr. Rader did a really interesting talk on the special needs for dental care and diabetes. And I heard it was really very fascinating and interesting, but unfortunately I couldn't listen to it because I was out at one of the tables. And so I wanted to ask him today, what is there the special need for someone who has diabetes and their oral care? What's the difference between someone with diabetes and someone who doesn't, and the need of, specific oral care?
Well, I'd say probably the biggest thing is uncontrolled diabetes affects your oral environment a lot. Mostly because when your diabetes is under control or uncontrolled, it affects inflammatory cells in your body, and so then you start getting bone reduction. And so when you see a lot of uncontrolled diabetes in the mouth, you see a lot of recession, and so the bone recedes away from your roots around your teeth to such an extent that your teeth become mobile or wiggly. And so the gums will swell up, and especially makes it easy for people that have their uncontrolled blood glucose level. It makes it so that it's kind of disguised with the gums being swollen, not realizing how much bone loss is going on. And it can happen quickly in some people, especially your ability to heal is greatly inhibited. So that makes it real problematic for people because they don't realize what's going on. They don't really feel it. They just know that their teeth are starting to get sore and they get a little bit wiggly. A great visual slideshow had a bunch of visuals I could show you that was
Just
really
pretend
neat.
like you're looking at this.
Yeah, and you could look at an X-ray and you can really see the difference, and that's where it really shows up, because you look at somebody and the lips are very forgiving, so they cover a lot up, and your gums will cover up a lot when they're swollen. And so, for instance, somebody that doesn't control their diabetes, they're going to have such bone recession around their back teeth and maybe even their front ones that it becomes very obvious, and people will come into the dental office and they'll have just tremendous amount of recession. I'll talk to them and I'll ask them if they have diabetes that run in the family. First of all, I ask them if they have it, if it's not on their health history, because sometimes people forget to put that on there. Then they'll say yes or no. Most of the time they say yes, it's in their family. And that's when I ask them that they probably should go to their MD, to the family physician, somebody, to find out. They might have to have a blood work done to see their blood glucose level and see if they might be in that category. Just because when you see it on the X-rays or you see it in the exam, it becomes very obvious. And then they come back and they tell me a lot of the time that, yeah, they have something going on. They're either pre-diabetic or they are, and they get their diabetes under control, and it helps out tremendously. Now, once your diabetes is controlled, then your blood sugar level is controlled. You don't have all the same inflammatory problems. So now your gums are healthier, provided you're still brushing twice a day, 2 minutes at a time, and flossing and all that.
All the things we're supposed to do.
Yes, and so then the swelling goes down, and then the gums hug the bone a lot easier. So it makes it a lot easier to see what's going on visually, not just with the X-rays, but now you can look in the mouth and see that. And it helps the teeth with your getting a cleaning in combination with that at a dental office, so that if there's still a good amount of bone holding on to the tooth, it still is basically you can use it. And at that point, then we have to see, is the tooth savable? If it has lost too much bone, then we just have to take them out, and we go down the road of partial dentures, full dentures, implants, if they're healthy enough for that. And somebody who has uncontrolled diabetes, we're not going to want to do treatment on them, because it's a lot of the time, if their blood sugar level is above 200.
That's what I was going to ask, because you've been telling me a whole lot of stuff here, and I'm going, I have questions. Yeah. The first thing you said, uncontrollable. So define uncontrollable. Is that 110, or is that 300
Blood sugar.
for your glucose level.
Yeah, the glucose level for a lot of people is between 75 to 125. There's different articles that talk about generally those numbers are the good ones that you want to keep in. Now, once you start getting higher, then it starts getting a little bit iffy what's going on. But once you hit 200 or more, there's definitely something going on that's not good, and it falls in that category of uncontrolled. And so once you can get your glucose levels back down to a controllable level, then it's easier for your body to react the way it should, and to not be unhealthy, or so that you can heal appropriately. You don't have all these inflammatory problems. People with diabetes have extremity problems because the blood is having trouble getting to and healing to feet, hands. A lot of people have the tingling in their hands and things along those lines. My mother-in-law has problems with her feet, and she has diabetes, and so she recently had a horse on her ranch step on her foot, and it was just the top of her foot didn't look so good, but she wasn't so sure she should go get it looked at because it just looked like a compression type bruise type thing. Just let it heal up, bandage it up. Well, she waited a little too long. It was only about a week. She went in, and it really was not doing well. There was some gangrene tissue on top that she had to have sloughed off. Yeah. And so her healing ability was greatly reduced, much less in the extremity. And so just imagine what's going on in the mouth as all this is disguised. Your mouth is the second fastest healing part of your body. And so your body's always inside your mouth is trying to heal and cover up things. But that's where it goes back to the lips are very forgiving to cover things up, and people won't smile if their teeth are not looking the way they want them to. And so then people begin to learn to smile differently to cover things up, but they know something's not right. And so that's why these regular checkups become real important, so that we can catch these things.
You said very quickly. So if someone has had uncontrollable diabetes for a month, 6 months, a year,
a few months it can vary in each person because they might have other contributing factors.
Okay.
Other conditions going on. But if you get a set of bacteria in your mouth that's not a favorable one, because we all have a good oral community of bacteria when you have healthy teeth and healthy gums, just like on your skin or anywhere else on your body. When you're healthy, you have a good, healthy community. And when one of those guys gets out of control, a bad set of bacteria gets in there, whether you're sharing a cup, spoon, or straw with somebody and they have a hole in their tooth, and you see that, you've got to be careful that they don't give you that bacteria through their saliva contact. That's why a lot of time it runs in the family with these like lovey-dovey kisses, with sharing a spoon with a parent to a child. You don't want to give them bad bacteria from your mouth. And so if you get an out-of-control bacteria, and then you have uncontrollable diabetes, it only perpetuates the problem faster. It makes it so that you can have, depending on the kind of bacteria, vertical bone loss quickly, versus it could be just over a couple months or over a year. It might happen a little bit slower per person.
And when you're talking about the gums swelling, would they be red or is it really noticeable? Would you notice it over time? I mean... Because sometimes I'm just saying, sometimes when things happen to your body, you don't notice it because you see yourself all the time.
Yeah,
whereas someone else would notice it. Do you understand what I'm trying to say?
I do. People put up with a lot in their mouth, too, before they are willing to go to the dentist, because there's a lot of dental anxieties.
Oh, yeah.
A lot of adults going around.
I'm there.
Yeah. Well, and that's part of the dilemma, too, is it's amazing the amount of pain a person will put up with before they go in, because they just keep saying, no, it's not that bad, it's not that bad. And then somebody will come in when they have this huge abscess. The gingiva inside is swollen, red, oozing, and then it starts to happen, a facial swelling that you can see because it's just so bad. And pain was their motivator to come in instead of a checkup. And so when we see a lot of that going on, then I try to convince people, let's not put out fires all the time. Come in for regular checkups so you don't have to go through this, because I have tons of people that come in and tell me that they have a high pain tolerance but just can't take mouth pain because it's a whole different ball of wax. It
it's
hurts.
In your head.
Yeah,
yes.
You can't get away from it.
So once you get your diabetes under control, then your gums will start to go back to where they're supposed to be, but your teeth are still wiggly, right?
Depending on how much bone you've lost at that time. So what the right ratio is a 2 to 3 ratio. You want about 2 being the crown that you can see in the mouth, the white portion of the tooth, to that same length of 3 being amount of root in the bone. So you want that much in the bone. Now, a lot of people get recession for various reasons. Plaque builds up. Plaque is like wet bread. You can brush it off with the same force that you take wet bread off of a countertop. And so it's really easy to wipe it off, but you have to actually do it. And so there was a lot of studies done where people spend about an average of 23 seconds a day brushing their teeth at one time. That's not even enough time for one quadrant of your mouth. So you should be brushing 2 minutes, timing yourself. 2 minutes is a lot longer than even I think, because at night when you're tired or you're trying to brush your kids' teeth, they just don't want to brush 2 minutes. And so that seems like forever. So having a timer helps.
So sometimes they will go back down to the gums to normal, and sometimes they won't, correct?
The gums will, when they're healthy, hug the bone. The bone
Okay.
level will never come back once you have that recession.
Okay, that's what I was going to ask.
Yeah.
They won't grow back.
They won't
They're
go
gone.
back, yeah. And now if you get a pocket bone or a pocket around a tooth of bone that vertically drops towards the root tip, and you have like 4 walls, almost like a cup, then there's a good chance you could get some of that to fill in if you get healthy again. But a lot of recession doesn't happen that way. It happens where it's the entire ridge around the root of the tooth. For instance, what holds our teeth in our upper and lower jaw is a ridge of bone called the alveolar bone. And when you take a tooth out, that ridge of bone atrophies or absorbs down because there's not the tooth there to stimulate it.
And that's why I've heard when you lose a tooth, you really do need to have something come back to
Yeah.
replace that, or else you're going to lose the bone.
Yeah.
And it could cause your jaw to look strange because you're losing that bone.
Well, and just by not having the tooth there, for instance, you see a fair amount of older people that have a lot of back teeth missing. You can see their cheeks look sunken in because they don't have that fullness there anymore, even the tooth, much less the ridge. And then the longer you're without teeth, the more the ridge resorbs down. So if a 20-year-old has a bunch of decay and gets all of his teeth out and gets dentures, by the time he's 80, he's going to have very little to no ridge to have those dentures fitting appropriately. And some people fare better than others, but most people, the longer you go without, especially those lower teeth, the thinner your mandible gets and the floor of your mouth wants to lift off your denture. Upper full dentures usually can suction to the roof of your mouth and be just fine, as long as you got that good suction. And you shouldn't have to use denture paste. You shouldn't have to use all that goo. A lot of people do, and they put up with a lot before they go get it relined, a hard reline to make it fit right. But bottom ones, if you have no teeth down there and you have a full lower denture, most people don't like them just because they come off when they're talking or eating, and it's embarrassing. So having some teeth on the bottom to maintain is great, because then you can have a partial denture to hang on to.
When you get posts that go down into the bone, will that keep the bone there?
Yes, and then you go into the consult with an oral surgeon or a dentist that places implants, and you look to see if you have enough bone thickness and height to place an implant. And there's different kinds. There's regular implants that'll last you the rest of your life, or should, and you can get little almost like a ball and socket joint type setup where you have the ball being the implant that's screwed on top of the implant, and then it's a gasket that's put on inside the denture, and it pops right onto that, so for the bottom denture. So it fits snug, it doesn't come out, and it's great. And you can get 2 to 6 of those depending on your situation for the bottom and or top. Most of the time it's for the bottom. The other option is to get mini implants. They're a lot easier to place, and they only last about 10 to 15 years, and they cost way less. But because they last 10 to 15 years, people that are planning maybe later in life, looking down the road, they're thinking, well, I'm not going to need my dentures in 10 to 15 years, or that works out about right. I won't need my lower denture in 15.
Of what I'm thinking, yeah.
Yeah. And so you have to kind of figure out, prioritize. Do I want the mini implants for a lot less, and they work great, and honestly should be the standard of care for anybody who has lower denture, low full denture, I should say. And then upper dentures, just make sure you maintain those. And then one of the important things that a lot of people don't realize is if you don't have any teeth, you still need to get the gums and the bone looked at on a periodic basis, once a year, maybe every 2 years, especially if they're a tobacco user. You want to get that oral cancer screening. How many times we see strange looking lesions in the mouth and biopsy them just to make sure it's not cancer of some type. And squamous cell cancer in the mouth is very common, especially among smokers or tobacco users. And so also taking a radiograph, pantograph around the jaw to make sure that there's nothing going on in the bones, see the bone thickness and make sure it's not too brittle, things along those lines, especially later in life. If somebody has other ailments and they're bone related, they manifest in the jaw as well. And so that could complicate things. And a fair amount of people, if they have a regular visit to the dentist, these things get identified at the dentist frequently before anywhere else because they're seeing their dentist more often. And so you'll see something that looks odd in the bone, it doesn't look right, so you'll refer them to their physician or refer them to an oral surgeon or an ENT, the ear, nose, throat doctor, because something doesn't look right. And a lot of the time they'll find out it's maybe some autoimmune issue that they didn't know about, now they can treat and they feel better, or it was some cancer we caught early on. Or it could be just something that they can easily adjust, and it was a vitamin deficiency. And so a lot of things show up in the mucous membrane of your mouth, and people get their mucous membrane in their mouth looked at a lot more than other areas, and so that it's a very sensitive area that will manifest things that are going on in your body, and they'll manifest in your mouth first.
You see it in your mouth first.
Yeah.
Well, I'm going to need to take a break, but I want to come back and continue this conversation because it's really, really interesting talking about. When you said even though if you don't have any teeth, you still need to go to the dentist,
Yes.
that was very enlightening to me. So we're going to take a break, and I'll be right back. Really?
Yeah. And a lot of people don't realize that.
And I guess because if you don't have any teeth, then the bone loss.
Yeah, the bone loss, oral cancer screenings, and then I can talk a little bit about the medical dental collaboration that we're doing at Durney is focused with diabetes.
I want to talk about that too. Okay, you ready to start back? And we're back. Welcome back to the Senior Moment. I have Dr. Justin Rader in here, and we're talking about, we started talking about diabetes and oral care, but then he kind of threw some curves with some really interesting information. But I want to step back for a moment. Mm-hmm. And you were talking about the wiggly teeth. Mm-hmm. Now, can you save those teeth if they're still wiggly in there? Do you put stuff around the tooth to hold it in, or what do you do?
Well, it depends on basically how mobile or how wiggly the teeth are. If they've lost too much bone and the tooth is not hygienic, or it will not come back because it's too wiggly, we have different levels to measure how wiggly it is.
Wiggly levels? Okay.
Yeah. So it's class 1 through 3 wiggly, basically. And if it's just a little bit mobile and it looks like after a cleaning, because a lot of the time there's that wet like bread plaque is there, and that's the house or the condominiums for the bacteria to live in. A lot of people don't get that removed in time, and it turns into a cement-like plaque. And from the minerals in your spit that want to remineralize your teeth, if that plaque's in the way, it gets remineralized. That's why remove it when it's soft before it turns into that cement-like stuff. Just by the presence of that, it causes more recession and makes it easier to recede. So by removing that, a lot of the time you're removing the bacterial insult and getting your blood glucose level under control. Helps the bone start to harden up a little bit. So if you still have enough bone level, then we can reevaluate after the cleaning, after a few weeks, maybe a month, and then you just do periodic recalls to see if things are looking better, if the gums are looking better, if the teeth are hardening up. If not, if it's a class 3 mobile, that means it just has this extreme movement, it's just not going to come back. And you can look at the x-ray and when the teeth are like that, you can see that there's almost no bone around a tooth, or it's in very little bone. It's just not going to rebound. And so that turns into issues of, now you've lost so much bone, now bacteria can get into the nerve either through a side canal that normally it wouldn't be able to reach because there would be tons of bone covering it. So now bacteria can get in through that, or it gets in through the very end of it because you've lost so much bone, and it turns into an endodontic or root canal situation.
Ooh.
So now you can get an abscess that's either, it's a gum root canal issue called a perioendo lesion, because it started out as a gum bone issue and turned into a root canal issue. And at that point, it's not worth saving it if it's lost so much bone. But that's where every tooth and every person's different. You want to take the x-rays, see the level of bone, see how loose the tooth is, and then you can evaluate from there. And is their diabetes getting better, or is it on the upswing and getting worse? And a good measure for that is a person's A1C levels. They measure every 3 months, or some people every 6 months, and you can get a good measure of if they're doing okay over the long term, as opposed to right now maybe their blood sugar level's just bad today and tomorrow, and then they can come back next week and we can do the treatment.
Right,
It's no big
right.
deal. A1C is good. But if they have an A1C and their blood glucose level's high, then they need to get that under control before we start pulling any teeth. It may take a long time for them to heal, and then there's a risk of dry socket, or it's not healing appropriately. But if the infection's real robust, then you definitely want to get that tooth out of there, but you want to make sure that they're healthy enough to do it. And then that goes into, well, they're not healing well. Do they have other issues, other health issues that complicate their blood from coagulating, or platelet levels? And so basically, will the clot in the clot and heal? And it's supposed to take about a week for the skin to heal over a site when it's extracted. And it may take 2 weeks if it's healing real slow. And diabetics, it takes 2 weeks generally if it's not as controlled as we'd like. And then people fiddle with them. You know, you have
Your tongue always
yeah,
goes to that spot.
Yes, and it's like you have a scab on your arm. Do you keep pulling the scab off? Is it going to heal? No, it's not very well. It's amazing our body can still heal, but now it has to heal from the bottom of that extraction site up. And so if you get a dry socket, it just hurts worse than an abscess for about 2-3 weeks. And so that's where really post-op instructions for something like that come in handy. And if people are listening, even though a lot of the time people only pick up 20% of what you're saying, so we give them the handout too, and try to go from there and see what happens.
And you know, diabetes is a major issue for seniors.
Yeah,
There's a
yeah.
lot of seniors who have that, and they have other medical conditions. You
Yeah.
were talking about blood clots and things like that. They have a whole lot of other issues going on. And I could see one of them going, okay, you know what, just pull it. I'm not even going to mess with it. But then when you start thinking about, well, if you pull the teeth, you're going to still lose the bone underneath that tooth. Then you know, it's a whole nother big issue.
Yeah.
So it's really important.
Yeah, it's important for the health of that spot because that tooth might have an infection around it, even if it has a lot of plaque and cement-like plaque, calculus. And then because it's now got this deep pocket from these inflamed gums, now you can pack food down there easily. So now you have a huge chance of that calculus or cement-like plaque forming, and so then you get more recession, compounded problem. And so just by taking the tooth out, you're already starting to heal because you don't have the bacterial insult there. Every time you're biting down on that tooth, you're injecting bacteria into your bloodstream, especially if it's an abscess.
And I have heard a number of cases of people who have died from infections they had in their teeth because it got into their blood system.
Yeah. Well, and a lot of people don't realize how much that much bacteria can really affect and get into your bloodstream. And when we have somebody that comes in and it's just too swollen, we have to give them antibiotics for a couple days, maybe 3 days. And then if they come in the following week, they've had it for 5 to 10 days. It works out great because then it's a lot easier to get them numb. So it's not painful to take the tooth or do treatment if you're going to do a root canal to try to save it. That way it numbs up easier. It's not traumatic for the person and painful. And dentistry has evolved over time. You know, you still have to get somebody numb, but it's not as bad as it was, you know, in the 1920s.
or 20 years ago for that matter. So, and when I think about that, when you're starting having problems with your teeth and they're wiggly, then it's going to make it harder to eat.
Yes.
And seniors have a tendency not to eat some of the things they're supposed to. So then that's going to affect their diabetes even more.
Yes.
Especially if now they can't eat because their teeth are wiggling.
Or hurt.
Or
them too,
hurt.
Yeah.
It's going to make it even worse. So it sounds like it's just, one of those domino effect kind of things.
Yeah. And then they don't want to come in because of anxieties, so they'll put up with it until it's to a point where the tooth is unrestorable, and then you have to take it out. And then we talk about tooth replacement options. And so then you talk about removable partial denture, bridges, if you have two healthy teeth on either side of the space, or implants, which are expensive but ideal. So then that goes into the whole deal. Well, are you healthy enough bone? If you have uncontrolled diabetes, your bone's not real healthy, and there's not a good prognosis for putting an implant in that until everything's healthy again. And so generally people go for the removable partial denture as an intermediate fix, but the longer you wait, the more the bone atrophies or absorbs down. Now you have less bone. Now you may have healthy bone, but there's less bone, so you might have to do some type of bone grafting or put the implant in a different site if you're going to do the implants. So that's why it's good to get that under control now, not even have to worry about it, and keep healthy teeth and brush 2 times a day. Use a fluoride mouth rinse at night is nice.
When you said bone grafting, what is
Right.
that? Tell me what that entails.
What that is when you need more bone thickness, basically, for placing the implant, because the implant is a titanium screw that you put into the bone. You want to have so much bone around it. And so if your ridge is real thin, especially the older we get with no teeth there, that bone, that ridge, especially the mandible, resorbs down, and you have very little bone to put in there. So now you have to look at either splitting the bone and putting graft material in there if their bone has enough height, and so you're not going to get that bone height back, and so you need to put in a shorter implant. So the more bone height you have, the better, because you can sometimes get width depending on how brittle the bone is too. The older we get, the more brittle-like bone we get, and so it makes it harder for having a good, successful implant the older we are.
When you said bone graft, is this our own bone that you take from somewhere else, or is it
There's different kinds.
manufactured material that you put in there?
There's both. You can get the manufactured stuff. You can get cadaver bone graft material and bovine graft material, which is from cows. And so
Okay.
and so it's this. Each one has its own purpose too. Some integrate over a longer period of time, like the bovine one. If somebody wants more time to think about getting an implant in, then you put the bovine graft material, because it takes longer to integrate and turn into the bone. But if you need something to take a little bit quicker, then you go for the cadaver or some of the other synthetic stuff. And so that's where it comes in important. What's your plan? What do you want to do? And what is capable? On the upper, our sinuses and our cheekbones wrap around a lot of the roots of your back teeth. So a lot of the sites there, if you have the teeth taken out, that sinus will now lay real close to the ridge of where the bone is now, because that ridge resorbs, the sinus comes down, and you have very little bone once the tooth has been gone for a long time there. And so that makes for a really hard site to put implants on the upper back area if you have had no teeth there for a long time.
Would your sinus open up into the roof of your mouth?
No, it opens up into the cheekbones as
okay.
a separate sinus. And then it goes into your nasal cavity is where your nostrils open up into. Right next to your nostrils, on the sides of your nose, there's a little opening that opens up into your cheekbone sinuses. When you take a deep breath, or you use those nasal strips at night that you put on the ridge of your nose, that feels like you're breathing easier because it's opening that up a little bit more, so the sinuses in your cheekbones feel like you're getting more of a deep breath, basically.
So if you didn't So if you didn't have teeth in the upper part and the bone started receding, it would not do anything to your sinuses. They would
No.
drop down, you said?
The sinuses without the root there, yeah, they'll drape over the roots, and without the root there, then it tends to drape into where the roots were, and so then it just stays there. It's easy to show you in an X-ray what I'm talking about, and for that exact reason, though, too, when you get an abscess or a tooth needs a root canal or a tremendous amount of recession, it can affect the sinus, where a large abscess has a good chance of draining itself into that sinus, and you can get pretty good congestion. And I see a fair amount of patients come in, and they've just had this chronic congestion problem, and this tooth that's been hurting them up there. And you can see that it's just caused all the congestion on the X-ray. You pull the teeth, their congestion goes away, and it helps out considerably. Now, that's not always the case for the congestion, but a good amount of time you can look at the X-ray and say, okay,
And see the connection between the two.
yeah, it's a good portion of the time that abscess is draining into that sinus if it's right there. It's like a little eggshell thin piece of bone between the root of
So
those
it's
back
not a
upper teeth.
not a big barrier there between the
Right.
two. Now, let's talk about, you were talking about your mother-in-law. I'm going to talk about my brother-in-law, who is diabetic, and he's on 20 different medications, and he smokes extremely heavy. I think he's on like 3 or 4 packs a day.
Oh gosh.
So
yeah.
what is that doing to his mouth?
Well, cigarettes, what they do, the cigarette air dries out your front teeth tremendously, desiccates them, makes it real easy for bacteria to eat holes in dry teeth, makes it easy for the plaque to harden up. So then now it's hard for you to brush off this cement-like plaque because it's caked on there. Your teeth are dry, and then the nicotine is a vasoconstrictor, meaning it reduces blood flow. So it makes it hard to heal in your mouth when you don't have the blood flow, but also the gums don't swell up like they need to try to protect yourself with antibodies and things like that. So it causes what should be a little bit of swollen gums to be artificially looking better than they should because the swelling's not there. So then recession can happen real easily because you got all this plaque and cement-like plaque, dry teeth, and it's a lot like dry mouth that you can get a lot of what's called xerostomia, dry mouth, from just having too many medications. A lot of medications dry your mouth out anyway, and so the more medications you have that cause the dry mouth, the more it makes your mouth dry anyway. So that if you're taking a lot of medications and you're smoking and you have diabetes, it's bad news for your mouth.
And so you may not know that the bones are receding because the gums are not swelling because of the smoking.
And then, and then they get a cavity they may not feel right away. And the bacteria eat a hole in between the teeth is a lot of the time where it starts, unless it's at the gum line because they're drinking a lot of coffee, tea, pop, all the acids that people don't realize how acidic coffee is too. I can go a whole nother spiel about that. But the bacteria will start by a little hole and it'll burrow its way through. And that's what we need x-rays to see, because where they contact, you can't see that visually. And then it balloons out underneath the enamel. And that's where you can really see it on the x-ray well. And while it's ballooning out, and you're not feeling it all the time because the enamel's mostly intact, so you're not feeling the sensitivity until it gets real deep and close to the nerve. Then it starts affecting the nerve, it swells. The nerve inside of a tooth has nowhere to go when it swells except for against the walls, so it hurts. And then the bacteria starts eating the nerve for food, and it becomes gangrene tissue when it's dying off. It's necrotic tissue. And so then that's why our body forms the abscess, is trying to throw down a separate environmental layer there, another skin layer to protect us from that bacterial insult inside that tooth it cannot get to because it has no blood supply to get inside to send antibodies to kill off the bacteria. So then that swelling happens and it gets bigger and bigger.
So if you have uncontrolled diabetes and you're a heavy smoker, you may not see these signs
Right.
of the gums swelling, that you're actually having bone loss in your
Yes,
mouth
Exactly. Yeah.
because the smoking is preventing it from swelling.
Yes.
And you could really have a more serious issue going on in there and not even know it.
And then if your gums are swollen or trying to swell for a long period of time, they become almost like a fibrotic or scarred tissue type of swelling that now, even after a couple cleanings, if you try to get on top of it at that point, the swelling may not go away right away. And so you have to just manage these deep pockets. But at least you know now that you're trying to manage it, and you know what you need to do. And so then you might need some type of gum surgery to help alleviate some of those problems. But then you see how much recession you have, and then it all starts coming to light. I shouldn't be attacking my mouth this often. Really, after you eat a meal, we attack our mouths enough in one day as it is. After one meal, it takes about a half hour for your mouth to recover, to get back to a neutral environment. Your mouth is in an acidic environment. So if somebody's has their meal and then they have a coffee afterwards, then
And they're drinking coffee all day.
exactly. And so now, instead of getting out of that half hour of acidic environment where your teeth cannot heal because you need a neutral environment for the minerals to remineralize your enamel, or you don't have spit because you have xerostomia and from all the medications, or the cigarettes are just drying out your mouth and reducing the inflammation, so it's making it hard for your mouth to heal. Then you follow it up with another cup of coffee, then you just stay in that environment longer. So it might take somebody who has a lot of dry mouth and smoking, it might take them 45 minutes to an hour for the mouth to get back to a neutral environment. And then they take another, drag off the cigarette and start over. Or they drink another cup of coffee and they start over.
So it never has a chance to heal.
Right. And so they spend all day long in an acidic environment in their mouth, and you need a neutral environment in between meals so that it can heal and remineralize. And so you can see how this just perpetuates, especially I like to have my coffee too, but I instead of trying to consume it frequently, I'll have a cup with breakfast. And if I'm going to have another cup, I'll have it with lunch. So I'm attacking my mouth all at once. And then in between, try to do things to generate more spit, because you need your saliva to bathe your teeth, not only to get some of that plaque off, but also to the buffers, to buffer your mouth to get back to a neutral environment faster. So you can use sugarless mints and sugarless gum to help generate more of your spit from your glands, especially if you have xerostomia or the dry mouth. And a sugar substitute that actually kicks out the bad bacteria and invites in good bacteria is xylitol. It's spelled with an X. You want to get it as the primary ingredient, and then that helps out tremendously to just by generating more spit from chewing the gum and the mints. And then the xylitol is just another help. It's not an end-all be-all. It doesn't do it all itself, but it's another thing to help get some of that environment in your mouth back to where it should be.
Good grief. All kinds of things going on in the mouth. Well,
Yes.
we need to take a break, but I want to continue this conversation and some of the things that the medical community is doing with the dental community. So we will be right back.
Well, yeah, a lot of people don't realize the air drying out the front teeth, and
Yeah.
then the nicotine reducing the blood flow, much less. And then then at the very end, I'll say, oh, yeah, and much less the cancer. Yeah.
I think he's, trying to slowly commit suicide, but anyway.
Well, 3 packs a day. That's you
He's
don't
more
see
like-
that.
No, he's more like 4.
Well, and
He's ridiculous.
most people, the most common number I see is a pack, maybe a pack and a half a day, but 3 packs. That's a heavy
he's
one.
a chain smoker all the time, and he's always got a cup of coffee, and he's diabetic. And when
Oh,
he was
gosh.
here,
Yeah.
we would make him move. Well, he moved to South Carolina,
Yeah.
and now he's gotten real big. He can't walk. He uses a cane. He's killing himself.
Oh gosh.
Okay, so what's going on with that you were talking about with the medical community and dental? Tell me a little bit about it before we start talking.
There, with the community health centers in Idaho, we're trying to get some grant money, and by getting this grant money, we're doing a medical dental collaboration. And Derny's focus is diabetics, whereas some of the other community health centers down south or in Lewiston, their focus is either children or pregnant ladies. And so to get the grant money, everybody has their own focus.
Subject, yeah.
And ours is diabetes.
And then you'll tell me kind of what all that is.
Yeah. we'll
Okay.
go
Okay. I
into
just
that.
kind of wanted to know what I was asking.
Yeah, no, that's fair. Yeah.
Okay, you ready?
Yes.
Welcome back to the Senior Moment. Again, this is Connie Clark with Home Helpers. And today I've got Dr. Justin Rader here, and we've been talking about all kinds of very interesting things having to do with our teeth and our mouth. And initially we started talking about diabetes and the effects on your gums and the bones in your that hold your teeth in. And then I kind of threw out a ringer and talked about smoking and got really scared at what he was saying. But there's something going on right now in the state of Idaho that's a collaboration between the medical profession and the dental profession. And Derny has their program going on, you said, having to do with diabetes. So tell me a little bit about what all of that is.
Well, part of getting the grant money is to have a medical-dental collaboration. And so Derny's focus is diabetics. And part of that entails, over on the medical side, if you see patients that have diabetes, we definitely want to make sure that they have a dental home, whether it's at Derny Dental or at some dental office, that they've had a dental checkup, because it plays such a big part. It manifests in the mouth so much. So then that goes into a little bit of a cursory checklist that the physicians at the medical side can go through. You know, do they have teeth? Do they have buildup? Do their gums bleed upon touching them?
Are your teeth wiggly?
Yeah. Well, and they don't have to go in and fill them all and all that. But, I mean, from those cursory things, you can tell that something isn't right, and then make sure that they've had an exam in the last 6 months or so. And then the contrast is on the dental side. If we see somebody who has diabetes and signs of diabetes that don't know they may or possibly have it, that they have a medical home. And so we refer over there to Derny Medical or to wherever their physician is, their MD, that they make sure that they have a medical home. And so we see a fair amount of people come into the dental office that haven't been to the dentist in 10, 15 years, or just haven't lost their, or I should say, have lost their insurance because of recession, lost their job, lost their insurance.
And the only reason they came is something hurts.
And the reason they came is it hurts. And so just by them coming in, they haven't been to a physician or to a dentist in a long time. So by having this collaboration, now we're not having to repeat, like when we're in the same building, being able to have the same health history, same medical list or meds list, so that we have the complete list. It's easier for them, easier for us. And a lot of older patients may have a laundry list of medications, and so they don't have to keep whipping out this big list or trying to remember. Or if they have a caregiver, then the caregiver may not know everything they have. And so then it makes it easier if we're in collaboration with the medical side. And then we can hold diabetic days too. And much like the deal we had in Panhandle Health District, where they come in, and especially once Derny Dental makes the move. Right now we're not in the same building as Derny Medical, and so we're trying to do the fundraiser deal. And so that's part of the deal, is just trying to get enough money to move the dental over to that same building and do some renovations there. And that fundraiser deal is coming up, but we're hoping to get over there in Derny Medical building this year. But once we have everybody doing those diabetic days in the same building, it makes the continuity of the exams real easy. We can go up and talk to a medical physician or one of the nurse practitioners, somebody along those lines, if we have some diabetic questions, or to just refer them up there because their blood glucose level is over 200. They're right there. Or vice versa. A lot of the time they'll see a patient and they just have this excruciatingly pain tooth that's just bothering them for who knows how long, but they just don't want to go to the dentist. They can refer them down, and it's a lot easier to just have them come down and take a look.
Well, it sounds like the two things are so very connected from what you were describing, what goes on in your mouth, and then what goes on in your body when you have diabetes. Both of these things are so very connected, and I would not have even thought that there was something that would happen in your mouth, although diabetes does affect your entire body.
Yeah.
So, I mean, I could see all of that being connected. So if you have diabetes, you really do need to pay attention to what's going on in your mouth. Because I would think that, you have to be real careful about cuts and that sort of thing, but you wouldn't necessarily think about your mouth, and especially with your gums swelling, well, gee, that doesn't have anything to do with my diabetes, but it would.
Well, and if you think about the community of bacteria in your mouth, if you have a healthy set of bacteria in your mouth, it's like having a good neighborhood, a good community in your mouth. Everything's good, everything's happy, but then you have some bad guys move in. They're starting to vandalize everything. You're getting cavities. And so then they start taking over. And then like any bacteria, it spreads from tooth to tooth because like a bacteria on the doorknob, you touch it, it gets on your hand.
And when you mention about, parent and a child sharing a spoon or sharing a coffee cup, I never even thought about that if someone has something going on in their teeth, that they probably aren't going to tell, the whole world around them that their tooth hurts or whatever. Yeah. And if you're sharing a coffee cup with them or you kiss them or something like that, that could come into your mouth.
Yes. Yeah. And it just imagine how much bacteria you have in your mouth. And if you have that constant bad bacteria there, you're swallowing it. Helicobacter pylori is one of the bacteria that causes a lot of ulcers in your stomach. And if you have that in the plaque or the cement-like plaque in your mouth, then you're just continually re-inoculating your stomach. You can take the antibiotics that'll help your stomach or get it resolved, but then the chances of it reoccurring are good if you haven't gotten that plaque community of bad bacteria out of your mouth. Your tongue is like a petri dish. You got to brush your tongue. You got to clean off the plaque around your teeth because it just has this community that's thriving in your mouth. And if you have a bad community, you're just re-inoculating your body over and over.
So it is very, very important.
Yes.
To pay attention to your mouth, especially if you have diabetes, because that can really do a whole lot to the rest of your body, because that's where everything starts coming in, is through your mouth.
Well, and a lot of the bacteria start off as these certain grouping of bacteria that are just start the inflammation. And once that inflammation takes over, and they're called aerobic bacteria because they like to breathe air and oxygen and use that to their benefit to live. But then once you get this swelling and you get these deep pockets, a different set of bacteria start taking over where they don't need the oxygen, and they're real deep, and they're much more erosive or pathological, because then they're the ones who start causing the root canal issues and the deep periodontal or gum and bone issues. And those ones can take off like gangbusters and cause vertical bone loss, cause a lot of bone loss fast. And they can get into your bloodstream real easily just as well. So it could start off as one set of bacteria, and then another one takes over. And then you just have this continual problem over and over until you get it all cleaned up. And so that's why it's real important just for the regular checkup. So we can tell you where to focus your toothbrush before it even turns into a cavity.
So if someone wanted more information on all of this, tell me how they would get in contact with you.
Well, Durney Dental, or you can call Durney Medical if you're looking for a physician. But Durney Dental, their number is 292-0697. And we had a phone tree that wasn't working so well. So if you called that before, we got that cleaned up. We had that for about 8-9 months, and it really didn't work well. Now it's much easier to get through. And then also, I work at Fulweiler Dental, and on my website, fulweilerdental.com, it has a little blog there. And it has some good information that talks about some of the things that we've been talking about here, but also fluoride and things that you can do with xylitol gum if you don't want to use fluoride and along those lines. And so people can look that up. And then
if you go online and just Google oral health and diabetes, I'm sure you're going to see a whole lot of pictures of what this really looks like. And the important thing is, if you have diabetes, you really do need to go in and see your dentist on a regular basis. And especially if you smoke, this might be going on in your mouth and you don't know it.
Yeah.
And by the time you find out, you could be past the point where your teeth can be saved.
Yeah, and people don't want to hear that a lot of the time, that it's not savable. And so they'll avoid going in, and then it just gets worse. And that's the dilemma. But if you do go in for the regular cleanings and checkups, then we can catch these things and try to maintain them. Or if they're not maintainable, you have multiple options a lot of the time, which
And
you
the
can
longer
do.
you wait, those options go down.
Right, exactly. And so you might have no treatment as your option because you don't want to do something, but then there might be a filling that you can do, or if it's real deep and it needs a root canal, the other option is to pull the tooth. And then we talk about tooth replacements if you need it in that spot.
So just pulling the tooth is not a good option. If you do nothing else after
yeah.
it, it's not a good option.
Well, it depends on the situation. Sometimes it is a good option for that person. If it's a wisdom tooth,
Oh, okay.
yeah. Or it's a second molar. Many people chew from their first molar forward. So if it's a second molar and they're trying to prioritize their finances or trying to prioritize their other teeth over, more front ones where it's in the aesthetic zone versus the back one, taking out the second molar is not too bad a deal. But then you take into account, is that going to have a chain reaction with an upper tooth? If an upper tooth has nobody to hit against, then there's a chance it could try to super erupt or try to extract itself a little bit, and then that causes occlusion issues. So that's why talking about all the options and coming to a decision, a recommendation, the autonomy of it, both of you have informed consent on what's the options, what are the recommendations, and then the patient decides.
Well, thank you so much for being on with me today. A lot of really good information out there. I think the important thing is get checked regularly, because the longer you wait, the less your options are.
Yes.
Thank you, Dr. Rader, for being on with me.
Well, thank you.
And thank you for listening to this Senior Moment. And you all have a wonderful rest of your day. Good day.